Yeah, I put together a small PowerPoint. This is obviously a hot topic in the state and around the country. So this is just briefly, and this is probably all information that everybody knows. I was talking to Ritu this morning when we were at Meritor, or was it last night? I can't remember where I was this morning or last night. It was this morning. I delivered a baby last night. Sorry, guys, I'm a little bit tired. So I still provide full spectrum family medicine. I do inpatient care at UW Hospital. I do OB care at Meritor and take care of babies, and then I do clinic, and it somehow works. It makes me happy, I guess. So I, just a little bit of background, I trained at Oregon Health and Science University in Portland, where I trained with Dr. Amanda Risser and Dr. Nick Gideons, both of whom are family medicine and addiction trained specialists that have a special interest in caring for women with opioid use disorder. So we had about a $350,000 grant from the Department of Justice to provide on-site care at a methadone clinic. So that's kind of my context of learning about this. And there's not a lot of data. There's some new kind of guidelines out that I wanted to talk about. But kind of the three things are, you know, since I have this lens and a scope as a primary care physician, is how do we identify women of childbearing age at risk of opioid use disorder? How do we assist any provider to provide medication-assisted treatment in addition to the behavioral counseling for women with opioid use disorder and pregnancy, and then to ensure adequate follow-up and referrals for concurrent mental health and medical comorbidities. PowerPoint is not very interactive. Feel free at any time to stop me. So just briefly about the epidemiology, at least in the state of Wisconsin. So this is a chart that I grabbed off of the DHS website, which is talking about how opioid use at time of delivery, which is kind of, for me, like kind of that, not that downstream effect, you know, we're trying to look upstream at prevention, but, you know, we have rising rates of women who identify opioid use, any use, whether that's prescribed oxycodone for back pain or heroin or fentanyl, and then as the concurrent rate of neonatal abstinence syndrome has also increased, but since 2013 has really kind of stayed stagnant, I think, given how people are treating NAS now in surrounding areas. We could go to the next slide because I don't know how to do that. So I just wanted to talk about screening. Again, as a primary care doctor, if a woman of reproductive age, which can be as young as 11 and as old as 50, walks into your clinic, I talk about doing a pregnancy test. And then if that's positive, it's, you know, this moment of, oh, what do I do? And I've had those moments. I just had a patient last week who I've been treating and has a child and goes, by the way, I have not had a period for the last 4 months. And, you know, me having the scope, I'm like, why do I not think of these things? Even I don't think of these things. But, you know, sometimes women that are in their recovery process may not get menstrual periods due to a wide variety of factors that influence their hypothalamic pituitary gonadal axis, if you want to call it that. And so I just talk about that. So if you have a positive pregnancy test, I usually give an SBIRT to all my patients. It's screening, brief intervention, and referral to treatment. I can give you guys a website if you're interested, but it's kind of, it's 3 questions that people ask. So I always ask, you know, for alcohol, I always ask about alcohol use. I always ask about what I call illicit substances, and then I do a PHQ too. And if any of those screen yes, then if you could go back. If any of those screen yes, then I give them a full DAST or a full audit, or I give them a full PHQ. And so and again, how do we then identify high-risk users? Because I have some patients that are like, I'm just going to keep doing heroin and fentanyl. And I said, okay, tell me more about that. And I said, you know, just trying to engage with folks, because there's a lot of shame in this area and around the country about this. And so how do we normalize treatment in a setting where patients come to access our clinics as a primary care provider? And then how do you appropriately refer to treatment? So I like this form. It works pretty well for me in the primary care setting. The ERs are doing a lot more of it. I wish the urgent cares would do it, but I think it's hard within their scope. We can go next. So you've identified somebody who's pregnant. I recently had a patient who was, the jails in Wisconsin and prisons are getting kind of into Vivitrol, got placed on Vivitrol in prison and, didn't think about birth control and is now pregnant. And so that's a very interesting case as well. But for treatment, the American College of Obstetrics and Gynecology, the American Society of Addiction Medicine, the American Academy, everybody agrees with this, committee opinion, which is from August. There is going to be a new committee opinion about Vivitrol in pregnancy. I haven't read through it yet. It just came out 2 weeks ago. I just haven't had the time. But for pregnant women with a known opioid use disorder, opioid agonist therapy, either with Subutex or with Methadone, is recommended and preferred to medicalized supervised withdrawal, because as Ritu, I don't know if she's still there, but you have high rates of relapse. She sees that at Meriter Hospital, which is where most of us that still deliver in family medicine deliver, and can lead to worse outcomes, not maternal and fetal outcomes. And, more research, they always have to put that in because that's what the lawyers tell them to do. If we could go next. And so I just wanted to go over methadone. Methadone comes in this bottle. These are take-home doses. I just found this on Google. It's been around since the 1970s. It has the most evidence in pregnancy. It's usually daily observed dosing. There's no risk for diversion. There's no ceiling effect. So I've had patients who have been on methadone in pregnancy up to 150, 180, 200 or higher. They have slightly higher rates of needle abstinence syndrome, and it's hard to tease exactly out why, that require treatment with morphine. And I think the other thing that's interesting is with needle abstinence syndrome is there's a nationwide push to change how we score patients. And so, and that's going to be really interesting to see what we actually do with NAS, because it's millions of dollars that Medicaid and health insurance companies have. However, methadone is very difficult to access in rural areas, and it's hard to get a hold of. And some patients do better. They need the daily dosing, and they need the treatment, and they need the behavioral support that a methadone clinic may offer. On the next one, we have buprenorphine or Subutex. This is what it looks like. It's usually office-based therapy where you prescribe a prescription. There is diversion potential. You do need to be in withdrawal, and that's a very interesting thing in a pregnant woman. So where I train, we just induce them on Subutex in our clinics. They would come in an active withdrawal. We would just check fetal DOP tones, even if they were 32 or 36 weeks. We very rarely would admit people to the hospital unless there was a indication such as low fetal heart tones. That is not done in the city of Madison. We admit all patients who are pregnant to the hospital to withdraw their opiates, to watch them withdraw, and to put them on Subutex. It is not a battle that I have the energy to fight, and so I have chosen to kind of just say this is very interesting, there's no data, and we're spending thousands of dollars. There is a ceiling effect with Subutex. I typically don't go beyond 24 milligrams a day total daily dosing, but there are less rates of needle abstinence syndrome. Again, this all may change when we choose to revisit how we score babies, and that's an entirely different lecture, and I'm happy to give it at some point, but I think with the constraints that we have today, it's hard. If I may have the next one, please. So conclusions, maintenance therapy is recommended. Dosing may need to be split or increased as the pregnancy progresses due to placental metabolism. Just a caution about that, postpartum, a lot of women can get very sleepy because we've had to double or triple their typical doses either of methadone or of Subutex. So I usually down titrate their dose, and I was allowed to do that when we were working in close conjunction with the methadone clinic through our grant and residency. Now it's very tricky to do that here because you have to get permission from the buprenorphine clinic, and there's this back and forth that needs to happen. There's numbers and after hours calls. There's just a lot of barriers. So there have been higher rates here. It's very interesting if you look at the infant death data, looking at what may be causing that. There have been more instances of babies, falling off the bed. There's no relationship between methadone dosing and buprenorphine dosing and neonatal abstinence syndrome requiring treatment. I think the big thing I wanted to emphasize is we use a Finnegan scale, which has a set of certain scores about sleepiness, tremors, diarrhea, it doesn't take into account that a lot of these women have concurrent tobacco use disorder, they have anxiety and depression, they're sometimes on SSRIs and multiple other agents, and that score doesn't necessarily take into account, is this true NAS from buprenorphine and methadone withdrawal? And so there's a new kind of method that's being promoted, and I find the data actually very good. It's called Eat, Sleep, Console. It's focusing on breastfeeding and nurturing and infant massage as a way to help babies get through a withdrawal period, whatever they are withdrawing from. And I try to normalize that for my patients and say, you are not a bad mother if you have a baby that needs to get treated. You have appropriately engaged in recovery services, and this is just part of this recovery process. I talk about postpartum contraception as soon as possible, as soon as I can get them into care, especially for women who have had 4 or 5 or 6 babies. It is nice to have them, if they would like a tubal ligation, per Medicaid and federal guidelines, you must sign that 30 days prior to their actual delivery date. So they have to sign it 30 days before their due date, otherwise it's invalidated. And they cannot get a tubal ligation, it will not be paid for, and it's actually against the law. I just write Subutex, not Suboxone. I know Charles Schomburger in La Crosse does continue Suboxone in pregnancy. I typically don't. There are medical legal obligations that I think, for me, I would not want to go in front of a judge and say that. So I just continue Subutex. There's one case report study that said Suboxone may precipitate neonatal withdrawal in utero, and so and most of the people in the country do Subutex over Suboxone in pregnancy. Growth ultrasounds have controversy. At Meritor, at UW, we do every 4-week growth ultrasound starting after 28 weeks. There is no data to support that. Nowhere else in the country do they do that either. And then I just recommend infectious screening every trimester and then on admission to the hospital, just because there are a high number of patients that have concurrent HIV, Hep C, or syphilis infections, in addition to gonorrhea and chlamydia, because a lot of these women do have to trade sex for money in order to get money for drugs. And then that's all I have. And then this was just a slide. I didn't know what to do with it, but this is the 5 criteria.
Hey, thanks a lot.
Question? I have a minute.
Just to reaffirm, we're doing a lot of pregnant women, and we're doing them all as outpatient inductions. We've had no problems. So just FYI.
Oh yes, hi Ritu. I was mentioning you before, so sorry.
I'm here, but that was Sheila who said that
we're doing outpatient inductions routinely. Yeah, with no problem.
Yeah.
Do you have a 130 patient? I have a quick question for you offline. Oh, where did she go?
Oh, sorry. Yes, I do. That's why I keep staring at the clock.
Okay.
They keep us tight in the clinic. But it's okay. I think they're rooming them right now.
I just wanted to share that the Subutex versus Suboxone question in pregnancy remains sort of an open one. There are a couple of places around the country, the Medicaid and sorry, Medicaid just simply does not cover Subutex at all. I think it's Tennessee or Kentucky. I can't remember which one. No, they just don't. And so they've just been continuing Suboxone through, and they did a population study, and they reported on it and said that the outcomes were comparable. So it didn't have any increased use. So based on that, people are more, and especially there are some women who just don't want to switch, or it takes longer to dissolve. They don't like the flavor. So for those people, I feel a little better with that data, knowing that if they want to, they can. But we talk about the informed risk. I document that we have this discussion.
And if it's a Medicaid patient, has a PA come back to you or something? Well, we don't have to do PAs anymore. Right. But has that been an experience in the past where they say, oh, no, you have to use the Subutex?
So if there was one Medicaid patient, and then we had to write that she was nauseated on the Subutex. There was some other issue that she had intolerance to the Subutex, not the Suboxone. So we were able to get it through that way. But yeah, we did have to answer to that question once.
I am still dealing with PAs with Subutex. I don't know why, but it's a pain.
Huh, yeah, you should have
Yeah.
to. You know, if that's getting pushed to you by the pharmacist is what I would.
Yeah.
Yeah.
You can push back on that and say,
That's
we don't
done.
have to do these anymore.
Right.
Is that just Medicaid or is that all insurances now?
Medicaid.
Just
Medicaid.
Medicaid only. So, yeah, if you
So-
want to just check and make sure it's not
Yeah,
the private
Medicaid and all the
insurance.
managed care Medicaid.
So Wisconsin got rid of PA for Subutex also?
Yeah, for buprenorphine products.
For all buprenorphine products, right?
Medicaid.
But not for Sublocade.
Not yet.
No,
No.
not so- correct.
And
That's
then-
yeah, because I've asked the pharmacist before. I work with the medicine shop here in town, and they're like, "Nope, we still need a PA," and it's
Huh.
very interesting. Yeah.
But even for Badger Care patients?
Yes.
Interesting.
Yeah.
I think it's,
So I've had to.
provide some education.
So,
Yeah. So I've had to do PAs for every single one of my pregnant patients because they're all on Medicaid.
Wow.
All right.
Maybe there's an opportunity for intervention.
Yeah,
Okay.
well, and we'll get back to the group with information too, see if we can follow up on that.